Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We are also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
What is head and neck surgery and why do people need it? There are all kinds of different conditions that happen, and we have two doctors with us this evening that are going to be talking specifically about that. I'm going to say this wrong, but I will be corrected, but maxillofacial surgeon is a doctor who specializes in diagnosis and treatments of diseases, cancers, injuries, and defects affecting the mouth, jaw, face, neck, and head altogether. So with us this evening, we have Hans Brockhoff and we also have Enrique Schubert. Both of them have German names but don't speak German, and I thought it was kind of fun that we get to have some fun with this evening. We have the program underwritten this evening by UMC, and the El Paso County Medical Society has bringing the show to you for over 25 years now. I'm Catherine Berg, and you are tuned in to the El Paso Physician. Thanks for joining us. Today we have two doctors that are very specialized in their skills. We have Dr. Hans Brockhoff, and he is head and neck oncology. And what does that mean? He's a microvascular surgeon. He's been in El Paso for 7 years. Thank you for being here. We also have Dr. Enrique Schubert, who is head neck oncology and also specializes microvascular surgeon. He is a fellow, however, otherwise known as a trainee. He's been here for a whopping, a couple of months, July 1st, I think you said?
That's right.
That's right. So these two are already fast friends, and we have had a lot to talk about before even getting on the air here. And one of the first things I want to ask both of you, and Hans, I'll start with you just because you're on this side. When we're talking about this specialty, so 15 minutes ago when you were explaining it to me, and you're like, well, up to a certain point, it's head and neck and removal of cancers. And then after that, you're looking at reconstruction and all the vascular happiness that goes on when you're doing that. Explain your discipline, if you would, because I know it's multi-tiered, as we were talking about earlier.
Yeah, so as you suggested, there's a couple different elements to it. The first is that there's the removal of the cancer. So that's the head and neck surgical portion of it. And so there's different cancers that arise. That's kind of a catchment term or a large term that categorizes a bunch of different cancers. Some of them arise from the salivary glands, some of them from the skin. Melanoma might be a familiar name for many people. Many of them arise from the oral cavity or the oral pharynx or the thyroid. So it's just a term that says these are malignancies of the head and neck. The second portion is the reconstruction. So after the tumor is removed, oftentimes it leaves a defect or a deformity or a hole. And so how do we fill that hole? How do we restore the patient back to their normal, what we would say, form and function? So how do they look and how do things move and function? So.
And you're looking at what people would, and I hate the words plastic surgery, but you're looking at rebuilding and reconstructing. And I'd like to talk about that a little bit too in the program. Dr. Schubert, I'd like to talk about for our audience. So when you're looking at training, Dr. Schubert's been here 7 years, and we'll talk about, you're a Navy guy, you said. Your parents, your dad was a Navy guy, so you're from all over the place.
Yes.
But hailed from Florida the last time you moved, and you also hailed from Florida the last time you moved. With being a fellow in training, if you can explain to our audience how that happens, because again, you're looking at tiered, and I think you said it earlier, you can be a teacher, but then what teacher are you going to be? You're going to be a history teacher, you're going to be a math teacher. Correct. So we're looking at being a physician. What kind of a physician are you going to be? And you're looking at head and neck, but now you're specializing even more. So how does that training occur?
Yeah. So what I'm doing right now is also called like a subspecialty, since oral maxillofacial surgery is a specialty per se. To become an oral maxillofacial surgeon, you need to go through dental school. Then you do residency, which involve also medical school. So it's a full training of several years to become medical doctor, oral surgeon, and also a dentist. And after you complete that, you can diversificate and you can go to other specialties, including craniofacial surgery, jaw surgery, even dental cosmetic surgery, like for dental implants. But one of them, which is the kind of like the highest top notch in our specialty, is called head and neck oncologic surgery and microvascular reconstruction surgery, which is what I'm
glad you're having a hard time saying that, because I had a really difficult time saying that in the opening. So this is the most specialized training that you can get with this area of the body.
That's correct.
And I keep wanting to call you Hans, because my very favorite uncle in the whole wide world is named Hans.
Okay, there we go.
Hans Richter.
Yes.
So Dr. Brockhoff, when we were talking earlier, when it's head and neck and removal of cancers, I know I said in the opening too that there's all kinds of different diseases, injuries, etc. You all specialize in oncology, is that correct?
That's correct. Yes.
So when you were talking about just, and again, even cancer of the larynx, you're looking at all kinds of stuff that needs to be removed.
Yeah.
If you can kind of set the stage for our audience on maybe a case or two that you've worked on in the past, where you can kind of describe, this is the type of cancer they had, the amount of tissue that needed to be taken out, and where you had to take it from there.
Yeah, and I think, maybe I'll focus in on, actually brought a case and some models. Would you like me to discuss that now?
I would love that. Yes, I love it when people bring toys.
So there's a lot of language and words that we're using, so I'm going to just try to make it really, really simple. The complexity for these patients is there's a lot we can talk about in terms of the logistics and getting someone. So if you walk into my office and you get an initial diagnosis of a malignant lesion, and it's a journey for them.
Yeah.
So they start in one spot and they're looking for hope, right? We all need an opportunity. And so most of the diseases are surgically treated, right? So I'm a surgeon and I operate within the realm of surgery. So I offer them a removal of the tumor and some opportunity to restore them. And then there are other pieces to that puzzle, oftentimes that they need to complete their care. And their care goes on for usually many years.
Yeah.
So one of the common things to have happen when you walk into an office is that you immediately start with the diagnosis. So that usually starts with a simple biopsy.
Say simple.
Yeah. Well, it's not
Everybody hears the word biopsy is like, oh.
Yeah. So it's a small sampling of the tissue, right? So you take a small piece, you send it to a pathologist, and that person looks at it under a microscope and looks at the individual cells and says, I'm identifying that this is the type of cancer that you have. It's of this tissue in this part of the body. So let's just say the mouth. The mouth is a common place for oral cancer. In fact, head and neck cancer is probably every year it shifts around, but I think for males and females it's slightly different. But in the top 7 to 8, usually number of cancers according to American Cancer Society. So the likelihood that you'll know somebody with head and neck cancer is very high. So this person will come into the office, we'll start the process of a CT scan. And this patient actually did not have a specific malignancy, but they did have a tumor of their jaw. And so there are also non-malignant cancers. But this person came to my office and they had a growth on their jaw and they noticed that it was abnormal and it was swelling.
So when you say growth on their jaw, on the bone portion of their jaw? Okay.
And I don't know what the easiest way to visualize this is, but this is a model of the patient with a CT scan.
Okay, gotcha.
And they do what's called a reconstruction of the CT scan to turn it into this model. So this is actually what it would look like.
Okay.
And it's very difficult to tell, but part of this is yellow, where the tumor is located, and the rest of it looks nice and white. So this would be like a normal appearing jaw here.
Okay.
And there's a deformity of the jaw. A piece of it gets sampled, and then we determine, look, this is your diagnosis, and this is our plan. So at that time, we have to develop a comprehensive plan specific for that patient. One of the considerations is how much tissue do we take to make sure that we ensure that the cancer is removed. Is this kind of how you would like to play it out? in terms of
Absolutely. Yeah.
Okay. So I'm not sure if I'm being too detailed, but
No, it's good because again, when you see a case study, and again, this is a real person's model of a jaw. So yeah.
So now I have to determine. All right. So how much tissue do I remove? So I actually send the CT scans off, and I get the help of a biomedical engineer. And through the visualization of the scans and a design, we can come up with something like this, which is a cutting guide. So what we're doing is we're designing a specific surgery for this patient. So they will provide this for me in the operating room to use as a tool to cut the tumor out. This is just
and
one
this is
aspect.
specific to this specific job because that's what you sent in.
That is correct.
Okay.
So I determined how much of this tumor needed to be cut out.
Wow.
So I received this. And this will guide where the tumor is resected or removed, right? So the saw goes through here and the saw goes through here. These holes also represent certain markers for how I want to adapt a plate. So this is just the removal, but that it's basically indexed. And it says, okay, I cut the jaw here, and now when I go to reconstruct it, I know how to line up the jaw in the way that I want to, because essentially I want the teeth to come together in the correct place, and I want the face to look normal.
So I'm going to stop you for a second because now I'm thinking in my head when you say, so this portion of the jaw now is, for the lack of a better term, cut out.
Yes.
Is there a healing process there? Because I know you said this is many, many steps.
Yes.
Do you close up at that point and there's a healing process? Do you start reconstruction right away?
Yes, that's a really good question.
Okay.
Most often the reconstruction happens immediately.
Oh,
at
wow.
that time.
Okay.
So this is a all-day surgery for the most part, late, usually into the afternoon. And so this is the first phase of the surgery, is the removal of the tumor.
Goodness.
So that then basically concludes that portion of the case. So the tumor is removed.
Okay.
And we can sometimes sample the margins in the area and then the pathologist in real time while they're asleep can look at it and say, yep, the tumor's been removed, and you can move on to the reconstruction.
So they can find all that out while you're in surgery.
It's
for the most part.
Not for the most part. Yeah.
Okay. That's a beautiful thing.
It's a gives you an idea, right?
Yeah.
Like, okay, yeah, I have a high degree of confidence that I remove this. And so this is really nice because they call these patient-specific plans, right? So this is tailored or fits only this patient and won't work on any other patient, right? And so the beauty of that is you don't take more tissue than you need, or you don't take less tissue than you need, because you don't want to leave tumor behind, but you don't want to sacrifice things or take things that you normally wouldn't want to take.
Exactly.
So now the patient is left with a difficult problem. The jaws, for example, for this case specifically, it was a young man, so he has all the remaining portion of his teeth, and he's missing roughly, by this point, half his jaw.
Oh.
So how do you rebuild something
in
a way that makes sense and brings his teeth back together, makes him look like a normal person, and potentially have teeth? Like, these are all the
just be
considerations.
able to eat something as simple as eating.
Quality of life.
Right.
I mean, how do the face is so visual. Everything you see in the world around you interact with, there's an element of your identity is wrapped into your face. And there's speech, swallowing function, all these things that you don't think of need to be restored. Because we took the tumor out,
right?
But how are we going to leave you?
Exactly.
So one option is a really good option is using one of the bones in the leg.
See, this is the part I think is interesting. It's like, where do you get your stuff from?
Yeah. So we gotta. I guess the term is like you gotta.
You have the first fellow over here chuckling. You're going to get your turn.
Yeah,
Trust me. We're going to have some great questions for you.
So you gotta. What is it? You gotta steal Peter to pay Paul.
Right.
Whatever the term is, you gotta take it from somewhere. So you either put something foreign in there, or the best thing to do is take part of the body.
So tell me why the leg, and I've heard this with other programs that we've done. Is it because the bones are larger? There's just more to take from. They're stronger. They can handle being shaved off a little. I mean, I always hear the big bone in the leg.
Yeah.
And why is that?
No, I mean, it's a really good question. We can use other bones. However, there's two main bones in the leg. There's the tibia, which is the really large bone, and that's the one that bears most of the weight. So that's what people run on. And the smaller bone in the bottom part of the leg, so not this is the most distant part of your leg is the fibula.
Right.
And the fibula is a smaller caliber bone. And one of the expressions we use in reconstructive surgery is that the fibula was God's gift to the reconstructive surgeon. So it's a bone that you have, but
I know I've heard about the fibula before.
So
okay.
you can you can take advantage of the fact that it's not a significant contributor or piece to weight-bearing activity. So I've actually used this bone in reconstructions on patients in the past, and they've gone on to run marathons and live a very high quality of life. Now, it would be a setback for someone who is an elite athlete, but for most patients, it's a very reasonable option.
Right.
So this is actually this patient's fibula. And so this is the caliber of bone. So you can see that it's not the same size as the mandible.
Mm-hmm.
But it's actually...
So you take the entire section of the fibula out? Is that what you're saying?
I'm sorry, you take a segment of it.
A segment of it.
So, it's this long, but, you have to preserve or protect or keep part of the fibula below and above to support the joint. But you can take the middle portion. And with this bone...
And so I'm embarrassed to ask.
No,
so there's a naked section there where the joint is connected, the top and the bottom of the fibula. But the middle of the fibula is gone, and it's gone. It's like out of the leg. There's
don't replace it. There's a hole there, and it fills in with tissue.
Interesting.
Yeah.
Okay.
You don't replace it.
And so your muscles then just learn to work around that and become whatever their new normal of strength is in that leg.
Yep.
Wow.
That's exactly right.
Okay.
Yeah.
Sorry.
No, those are great questions.
I do those interruptions.
Yeah.
So if I need to clarify it for me, I'm thinking somebody else is probably thinking the same thing.
I hopefully you can follow me here.
Yes.
Hopefully I'm making sense. So now, we remove the cancer. We're still on the rebuilding of the jaw. So this is the bone that we're going to use to do that. What they also provide, so this is also for this case, this is a cutting guide for the fibula, and it fits in a specific spot. And, there's a lot of different elements that I won't explain, but it slides onto the fibula in a way, and I probably won't orient it exactly correctly on this program, but it's going to do something like this.
Mm-hmm.
And this will allow me to section and shape the fibula in a way. This is a different, is not specific to this, but it'll let me section and divide it in a way where I can shape it and it'll fit into this spot. One of the advantages is I'm able to place implants into the fibula that later teeth can be mounted on.
Exactly. Okay.
So that is often done while it's on the leg. So I design where the teeth need to go, the implants. So the whole surgery is planned before the patient even gets to the operating room.
Wow.
So when this gets transferred up to the jaw, there's a plate that connects it, and then there's implants, and then they can get teeth. So their whole jaw literally goes from being removed to being reconstructed, the jaw as well as the teeth, in a relatively short period of time.
And the fibula is removed ahead of time?
So
it's fascinating to me.
All done. This is all on the same day.
It's all on the same day.
So here's what has to happen. In order for this bone segment to survive, it needs to have a blood supply.
Right.
And in order to have a blood supply, there's a couple blood vessels. There's an artery, so there's a couple blood vessels that run with it, a few actually. And then there's some veins that run with it. And when I bring it and transfer it to the head and neck, I tunnel the vessels. Imagine there being a blood vessel running right here along the fibula.
Mm-hmm.
So here's one segment and here's the other. The blood vessels run down into the neck, and the blood vessel, a typical blood vessel coming off of here might be like the size of a noodle or something.
Okay.
So it's not big. It's a few millimeters in size. And that goes down into the neck, and I connect them with a microscope using small suture to vessels in the neck. And so what happens is the blood comes off the main artery in your neck is called the carotid artery. So it comes off the carotid artery into a little blood vessel and goes all the way up into the bone flap. And then it circles through the flap and then comes out through a small vein and drains back into the neck. So essentially, what am I describing? It's a transplant, right? It's an auto transplant. You're transplanting tissue from one part of your body over to the other. And so...
But you've got all those tubes and cords you have to do. This is what you were talking about earlier with all the special training, the most specialized training. Okay.
So it's so you connect the blood vessels and the nerves with small suture. The suture is about the size of an eyelash or a strand of hair. That's about how thick it is. very hard to see with the naked eye.
Right.
But under a microscope with small instruments, you can see it and connect the blood vessels together.
So I'm thinking all this is in one day. And we have Dr. Brockhoff's in there, and then is Dr. Schubert helping you out? Like, who else is in there?
Mm-hmm.
Because you're looking at dentistry, you're looking at all kinds of
Yes.
teamwork
Yes.
that's happening in there.
Yes.
And this is where Dr. Schubert,
Yes.
since you've been here since July 1st, have you assisted in some of these surgeries? Are they
yes.
so talk about how the back and forth goes between you guys or between whoever it is that you're working with. Because I just feel like, number one, there's so much going on
Okay.
during this one day surgery.
Yeah, I know. So there's another surgeon that is part of our team. His name is Dr. Arshad Kalim.
Mm-hmm.
He came from Miami as well.
Wow.
Yeah.
A lot of Floridians. Yeah.
And he's a microvascular surgeon as well. And they work, Dr. Brockhoff and Dr. Kalim organize their cases to work together in the same OR. So while Dr. Brockhoff or Dr. Kalim is resecting the tumors in the head and neck area,
Mm-hmm.
the other surgeon is harvesting the flap from the leg.
Wow.
So
Okay.
it's a combined case, both surgeons working at the same time. And when the tissues in the head and neck area are ready for the tissue transfer from the leg, they just join together in the head and neck area and work together to reconstruct. So that make it possible to do it in one day.
Right. And you were saying too, you want blood flow to be continual. You want to be, the patient's obviously anesthesia for all these hours too. How important is it? And I'm just thinking speed, this is not a speedy type thing, but in general, as surgeons that specialize in this, which is not in any way, shape or form a quick surgery, how long, I can't even say average because every case is so different. How long is it okay for a patient to be out on this kind of anesthesia for? Like, how long can a surgery last until it's like, oh, we need to maybe continue tomorrow or the next day? And then my next question is going to be, what are some problems and hiccups that you run into? But in general, how long is it okay for a patient to be out?
So if you think about it, there are patients that they are in the ICU, sedated under basically general anesthesia for weeks, even months. So anesthesia today is a very safe method to put patients to sleep, and they are completely monitored during this time. Their vital signs, heart rate, and they can control any problem with medication as well. So that's not a problem. But
So if it takes you 10, 12, 14 hours, it takes you 10, 12, 14 hours.
That's
It's not an
correct.
issue. Okay.
Yes.
All right.
it's not ideal that a patient is under anesthesia for that long. That can bring other issues in the future.
And that
their
was
recovery.
my question about that. Yeah.
Yes, but in general, they tolerate anesthesia pretty well. The
Okay.
surgery is much more aggressive than what they have
And
from the anesthesia.
Well, that makes perfect sense to me. So I have a question here because the part that fascinates me, and Dr. Brockhoff, you touched base on it, is again, I'm going to call it the tubing,
Yeah.
right? You're looking at nerves, you're looking at vessels, you're looking at just everything that needs to be transplanted. But if you have the carotid artery, I know you can't really mess with that. That's too dangerous, right? But do you get is the tubing all tubing that's already there? I'm just going to call it tubing for the lack of a better word. Yeah. Or is some of that also transplanted from the leg? And as a fellow, this is something I think you were talking about the last part of the training and what your specialty is.
Yeah.
Is the if we're going to put it here, the microvascular surgeon portion of it. This is microvascular surgery.
That's right.
Yeah. So talk a little bit about that.
Okay, so as Dr. Brockhoff was describing, so the tissues need a blood supply to survive, right? So when we harvest a bone from the leg, it comes with some other soft tissues attached to it. And imagine like doing plumbing, as you say, we're talking about tubes. So one vein, like one artery coming in to provide blood supply, and one vein coming out to drain that blood that was coming in before. So when you transfer that, you need to find, it could be a branch of the carotid artery, which are mainly the branches that we use for this. But we can explore other arteries of the anatomy that we can use as well. Whatever we find that is good for this, we will use. So you hook up the arteries as doing plumbing and the veins, and that will provide the blood supply. But of course, that requires a dissection and exploring the neck.
Exactly.
And also preserving the vasculature that's coming from the leg intact. You cannot damage the arteries or the veins, because it can compromise the blood supply.
They have to be perfect when they go through.
That's correct.
And I'm just thinking too, with the cancer that was taken out, and I know it's different with every case, but let's just talk about this gentleman because he's in front of us. How many veins, arteries, no, but how much was removed when it comes to the soft tissue tubing in a situation like that? Was the fibia able to then replace all the tubing that needed to be replaced? I hope I'm asking that question right.
They're good questions. So you try to, when you do things, you try to preserve the structures that aren't directly involved with the tumor. So the tumor will determine or dictate what comes out.
Okay.
And you repair what you can. And you can't sacrifice certain structures because it's not compatible with life.
Okay. Because it's not compatible with life.
Exactly.
Wow.
So
nicely worded.
There are some limitations to what you can do.
Mm-hmm.
Now, certainly if you have an injury to a very important structure, I would do everything I could to repair that, because the tumor was there or the cancer was there, or we had to take something that we normally wouldn't have taken.
Mm-hmm.
So in this case, the body is really beautifully designed in a way where even when you damage certain structures, like, so let's say they're not a dominant artery or vessel or something that you're identifying, it will over time create a new network, a new system. It will infiltrate and grow into that. We call it neovascularization. So it grows and revascularizes an area that's been
regenerates what it needs to generate. Okay.
So, but the important ones we do, and the ones that are critical, as Dr. Schubert was describing, the ones especially that we're connecting, they have to be handled extremely carefully, very delicately, and even the smallest, like a scratch on the inside of the vessel can be enough to, because they're so small, can be enough to create a clot. And
right,
a clot,
exactly.
If you think of a clot, like people can like the analogy would be like a clot in your heart or a clot in your brain, like that's a barricade or a blockage, and now blood doesn't come in or blood doesn't come out, and the flap won't survive. So that's those are not very common, but at times it can happen.
So that leads me to a question, and Dr. Schubert, I'll ask this of you, of the tools that you're using. And as you're speaking about the delicacy that you need to operate these tools with, but then also the sizing, and I'm thinking about nerves, and I'm thinking about tiny vessels, about the types of tools that you're using. And I asked earlier before the program, is any of this robotic? And to your point, very little, if any. This is all human-led, which is kind of neat, because some people are like, why is a robot operating on me? I remember years ago, we had so many questions about that. But describe in your training right now, what types of tools are you using? And maybe even describe what tools were like 5 years ago and what you maybe picture tools being like 5 years from now. Because I feel like we're constantly in an evolution of things that we're able to use.
Yeah, so part of the skills that I'm learning in this training program is to do microsurgery, which is different from conventional surgery. When you use your hands, you tie sutures with your hands. You can use big instruments and use some force to manipulate the tissues. When you're finished with that part of the surgery and you jumped into the microsurgery part, you need to switch your fine movements of your hands, and you need to be very delicate because you use instruments that the tips are maybe 1 millimeter or less than that in diameter. So when you see in the microscope, every small movement looks like a huge movement.
Right, exactly.
So this is something that you need to train in and create those skills in order to perform.
And no coffee that morning.
Actually, you can have coffee. They recommend to just do the same thing
He's
that
thinking
you
I
do
have
every
coffee,
day.
and I'm like, there's little tiny twitches going on.
I mean, if you're a
Goodness.
coffee drinker,
All right, then
you
you're
just
fine.
continue doing
Yeah, you just.
what you do. Yeah.
Goodness gracious. So in your training, because again, you're looking at not massive movements, but when you're looking at these small movements, and this may be a silly question too. Do you have extra? Let's say that this vein, I've got an extra vein on the side just in case I screw up this vein. I mean, is that even a thing, or is it? And I know that they're just pliable. These tubes are pliable.
Of all, we
yes.
never mess anything up.
I
So
love
let's
that.
just-
That was a disclaimer at the beginning of the show. You know, things happen. This is the view of, but these are just questions that I'm thinking to myself. The audience member's like, okay, well, what if, something, and that happens, right? There's a little tear here and there that you're like, okay, well, this one we can't use. What happens in situations like that? And these are terrible questions. Doctors hate these questions.
No, they're great questions. This is a great question.
I'm hoping they're fun.
Yeah, they're fun
Okay.
questions. Yeah, so you try really hard to not get in those circumstances.
Right,
So a
of
lot of
course.
it is preventative.
Mm-hmm.
And you can be really resourceful in repairing and finding other opportunities elsewhere.
Right.
Now, occasionally, you can be in a situation where you may end up making a decision while the patient's asleep, and all these conversations are had beforehand, right? So everybody knows and understands that it's a high-risk surgery, and that the stakes are really high, but the reward is very high.
Absolutely.
Right? So, and these patients understand that. And truthfully, I see them multiple times in the process of working them up. And so we have these types of conversations, not in gross detail, but certainly like, look, you just have to trust that I have your best interests in mind, and I'm going to do everything I can to get you back to who you are and doing the things that you enjoy. So, and I think, for the most part, those patients are very understanding of those things.
Yeah.
So when those situations arise, sometimes you have to use something that you normally wouldn't use. Like, so for example, I can't find a vessel. I don't know where to hook up to. I think that's maybe a scenario
That's
that you're
exactly
thinking.
what I'm thinking about.
So,
yes.
So we say, okay, there's nothing available on this side of the neck. Let us open up and explore the other side and see if there's something available, because that's nowhere near where the tumor is, and see what's available. And oftentimes that's a solution. Now, patients who maybe have already had a surgery, they've had radiation treatment. There's a lot of different things that could complicate a surgery that you can get into. And so the expectations have to be discussed ahead of time. And you say, look, we may open you up, and we may find that the tumor which is really rare, but simply there's a portion that may not be resectable. We can't sacrifice that structure, or we may not be able to reconstruct you the way that we want to. And so they may not be a candidate for this specific reconstruction, and in which case you may use less than ideal reconstruction. For example, you can take tissue from nearby that's just soft tissue, no bone,
right,
and you can transfer that. And so there are other options, but they tend to be a step away from like an ideal.
Right, exactly.
And so, but yeah, there's.
Well, it's nice that there is that extra option there too.
Yeah.
Question here, if and I'm going to talk to Schubert. I'm just going to, because it's your turn.
Okay.
And Dr. Brockhoff, if you need to come in on this, but when you are determining, and let's move away from cancer for just a moment, and let's just say that there's been now a traumatic injury, either a fall or a car crash or something, and so part of the face is at a point so injured that needs to be removal, maybe a jaw was busted, etc. How is the diagnosis made? And I'm thinking trauma, because there's not the amount of time that you may have that if a cancer situation would be there, because then you kind of have time. And a trauma, it's coming in emergency room. I don't know if that's something you all deal with a lot, but when you have to make a decision that's a lot quicker than being able to consult for weeks at a time, I don't even know how to ask that question, but do you just go in there? Is it a surgery you go in and try to figure out what you can salvage at that point?
Yeah,
That's a tough question, I know.
Yeah, but it's a very good question as well. And let me tell you, coming from Miami, the training I had there in oral maxillofacial surgery involved a lot of trauma. Miami is a place that there's a lot of car accidents and high energy trauma and a lot of gun violence. So we've seen and we've treated patients that have from the simple fracture that you don't need to do anything, or maybe put some plates and screws to fix a jaw, to avulsive high energy trauma, which means that the patients have a part of the tissues of the face and even bones from the face missing that they were left behind in the scene. When you have those scenarios, first is the initial management of those patients. So they need to stabilize and be sure that he can breathe. He has a blood return from the blood loss they had. So they transfuse the patients if they need to, and save their life. And then is when other specialties jump in and start treating what's needed. A neurosurgeon, a general surgeon who has an internal bleeder. And we jump in as well to address the facial part, right? So there are cases that if the part of the jaw is missing, also usually soft tissue is missing as well. And you need to reconstruct that. And a very good option is to do free tissue transfer, which is what we've been describing here. And the earliest you do it, the better, because you
I was going to say, because I don't know if that would be, like you were talking about this day-long surgery. In a situation in trauma, I'd imagine you can do as much as you can for a bit until you're able to get together a team and figure that out. So
you basically start making a line with other physicians, and the ones who get priority go first. The neurosurgeon go, and if there's an intracranial bleeding, they manage it. Then, I mean, we are maybe like the fourth in the line, and then we just
you
jump
said you were
in.
first at the beginning of show. You're like, hey, we're the most specialized. Just saying. No, but that makes sense. What was the wording you used earlier about saving your life? Life.
Yeah,
that's correct.
Yeah, but as long as it gives you life.
In the past, they used to just temporize it. Like, okay, let's make it. They stop the bleeder, and we'll make a surgery in 1 month. And when all this heal. But we found out that all the tissue contraction from the scarring and all that make it more difficult to reconstruct after. And if you do the reconstruction the sooner possible, you have a better outcome.
Okay. When does scarring start? Is that, I know it's I get that it's immediate, but how long does it take until the scarring is just like, it's a little bit too hard of a tissue? And again, it's different with everybody and it depends on age. But ideally, if you're in a trauma type situation, do you want to get back to that patient within a couple of days? Or is a couple of weeks too late?
No, I within 1 month, I think it's safe to say that you don't have that much scar that you need to break to start making space for a reconstruction.
Our body's magical, but not that magical.
Correct.
Doesn't repair itself that fast.
But there's some injuries that, like burns, for instance.
Right. Oh,
they create,
you know what? We haven't talked about burns, right?
Yeah.
And again, I think a lot with you all is bone, soft tissue, and then again the tubing. But with burns, I just think about soft tissue, but I guess that's not necessarily the case, right?
Yeah. I mean, the soft tissue they're very sensitive to high temperatures, and they can produce burns easily. One type of burn that we see all the time is actually secondary to cancer treatment, and it's called radiation therapy. And that is basically a type of burn, but it's a curative treatment it's called an adjuvant treatment for cancer.
Right.
And the intention for that is to kill any cancer cell that might be behind after the surgery. But the consequence of this is that it will produce scarring of all the tissues, even the muscles inside and everything.
Right.
And it can produce something called osteoradionecrosis, and it's long term, but it's basically burning bone.
Oh, really? Okay.
Yeah, because the radiation goes easily through the soft tissue, but the bone is so hard that it won't go through it, and the jaws or the maxilla, upper jaw, will absorb all that energy of the.
So what does it do to the bone? Does it start making the bone more brittle, burning?
Yeah, it kills the bone.
It kills the bone. So are we talking about Mr. Fibia again coming in and helping save the day?
Yeah.
Okay. See, and that's what's so interesting. Again, I've been hearing about fibia we've been doing this 25 years. The fibia is like the magic bone.
Yeah, it's a great option.
In situations like that, Well, I guess again, we've already answered that question of how long does it take to, get the scar tissue and what have you. What I want to do, because I'm getting too fascinated with things, we have about 17 minutes before we end the program. So what I really want to do is focus on what you all wanted to talk about as you came here this evening. I've got tons of questions still that I want to ask of you, but I don't want to get to a point, and I didn't talk about this before the show, I usually do. I don't want to get to a point to where you're like, oh, the show's over and I didn't talk about A, B, and C. So, Dr. Brockhoff, is there, and I love that you brought these, and congratulations to you for the gentleman that gets to live a okay life and, eat some cereal and hopefully some ribs. But is there anything that you really wanted to talk about this evening that either we touched base on already, or that you'd like to talk brand new about? Like I said, I've got all kinds of stuff, but I want to throw the floor both your ways.
Thank you. Well, let me, I guess, one of the things that I touched on was the journey of the patient, right? And that it's head and neck cancer is actually relatively common if you start asking family members and friends. And so, one of my dreams when I came to El Paso was to help develop a center where, for lack of better terms, a head and neck center of excellence, where patients could go and be treated in a way where they receive care at the highest level. Because one of my observations when I first came here was that many of these patients who were not able to identify a surgeon who was able to execute something like that would be left with the option of having to leave town.
Right.
And so if you just wrap your brain around what that means, like I have to get in a car or get on a plane. And many, probably the closest area you could go to from here is Phoenix, which is like a state and a half away, right? Or you could go to Houston. Many people would leave and go to Houston. And so I think one of my goals was to make it possible for someone who could stay here, receive their cancer treatment, and receive care at the highest level. And not only that, but one of the things we've been talking about is launching this fellowship in the training program. And so
with Mr. First Fellow,
with
here?
our first fellow here.
Yeah.
And so exactly. And Dr. Kaleem, I'm so sorry he couldn't be here. He's our other faculty, but is to really construct a team, right? To have something where we could go and create an impact in the community. And really, many of these patients, they drive 4 or 5 hours to come see our team.
Right.
And to get their surgery, they get to be in their home around
and
their loved ones.
And I'm so glad you're saying that because the support system, sure, getting in a car or on an airplane, but the fact that you have someone that lives in your town, whether you're married or not, have mom or dad around or not, or you have your people, whoever your people are. And when you're in another town in the hospital, or even if you're staying at a hotel or something, you don't have your people around, which makes all the difference, or your dog, or whomever. So it's such a big deal. And over the course of the years of doing this program, I'm so proud of us when I say that, our region, of bringing in so many new treatments that even 5 to 10 years ago people had to leave town for. And it wasn't about leaving town. Fine, that's one thing. But you're leaving your family, you're leaving your best friends, you're leaving the people who care for you. And it's just high five to, and I know UMC is doing this show, underwriting this show, and it's only sometimes as good as, and people talk about money all the time, and money is icky. It just is. But without that, you can't buy the instruments that you need and the tools that you need. And, you wouldn't be able to send this off to a lab and maybe have some really cool 3D place make it. And I would love for you to think about, and this would be the same question for you too, just looking forward. What you've seen, so you've been in El Paso 7 years.
Yes.
You've been practicing in this world about how many years, más y menos? And what you've seen differently from then to now.
Yeah, I mean, my whole training, the whole training takes about 15 years.
Okay.
And so then you just add 7 years to that. So that's been the entirety of, starting from day one, I don't know anything to where I am. So I think the future is very bright. I would say that I do think we're, from a surgical perspective, a standpoint, we're offering care at the highest level. So these patients that come to get these types of reconstructions, I would say you go wherever you want. try to find.
But we have it here.
Well, we have it here.
Nice.
And so that's really special. It's a special gift. It's something for the community, for the region. And I have to thank, all the support for, UMC, University Medical Center, for helping us to develop, these types of, and other hospital systems as well. But they've been really supportive in what we're doing. And it makes
you're
it
seeing
possible.
patients from, it does. And you were talking about, you're seeing patients because we are somewhat isolated in our region. And so patients are coming in for 4 or 5 hours away. So we're looking Deming, Dallas would be the next. No, you were talking about
probably more like
Arizona.
Yeah, I would say maybe Midland
Okay.
patients. I do get patients from that Midland, Odessa, and once they
Okay.
start getting closer to Dallas and Fort Worth, then they start heading that direction.
Okay.
But a lot of southern New Mexico, even surprisingly, you'd be surprised, but I get quite a few patients from northern Mexico, the Chihuahua area.
I'm not surprised at that at all. Not at all.
And so they come up, they have their diagnosis, and they're like, we heard this is where to go to get cancer treated. And I've had a few patients from Arizona, but that's unusual because they start to head towards. So we have this huge catchment area.
We really do.
And so you can't think of it El Paso in isolation. And so what's the beauty of that? It's like we become this regional center for people to come and, not just El Paso, but, this huge swath of area. And so, I think it's, moving forward, what's next? I think we just keep growing and expanding it, grow the team, and make it bigger, make it as great as we can,
So, Dr. Schubert, when you were looking at coming to El Paso, what was that recruitment process like that? Was it something that, I'm looking at El Paso? Was it El Paso that came after you? And I'm just thinking about that. If you're looking at growing the team, and I know this isn't medical per se, but it comes to the point of how do we build this? How did you decide to come here? What was that process?
Well, I think what High Desert, UMC, Dr. Brockov with Dr. Kalim and the rest of the group are building here has so much potential. I think it has the potential to become the #1 program in training in head and neck in the country. And
say that again.
Yeah.
I kind of like that. It has the possibility to become the #1 head and neck surgery training in the country.
That's correct.
Nice. Okay.
So it has a lot of potential, and the community here needed something like this, and they are building it here. So I want to use this opportunity also to talk to the community, to encourage them to, if they have any family member, friends that need an evaluation from any potential oral cancer, they notice something wrong in the neck or inside the mouth, to come and get a consultation for an evaluation. It might be nothing. If it's nothing, well, they were lucky to meet the fellow that day.
Right, you got the first fellow.
Exactly, the first fellow. But if it's something, we can definitely help them or guide them through to a treatment plan and make a decision, for treatment.
So here might be, were you going to say something?
Yeah, I wanted to add something.
Yes,
I didn't want
absolutely.
To interrupt.
Yeah.
If I may brag about Dr. Schubert for a second, these are, to go on to this level of training, for those, many people are probably unfamiliar with medical training. So you go to you go to either a dental or medical school, and it's usually some combined program, right? So you get training in both dentistry and medicine, which is really unique to our specialty. And that takes a big chunk of time. Then you do your residency. And then after that, you can go out and be a doctor and do all the things you want to do. But he pursued training, and this is what we're using the term fellowship. So he's already a full-fledged surgeon, doctor, all of those things, and he is specializing in something that very few people do. So it is a highly competitive situation. So, and he's a very talented and gifted surgeon. He won't brag about himself. He's very humble. But so we're very fortunate to, and our next fellow coming next year will be coming from NYU, New York University. He comes highly recommended, highly recruited. So we do, and I think, back to your question on what makes El Paso unique and special. I mean, some of it is the team that we've constructed, and some of it's the community, some of it's the support of the hospital system, and the uniqueness of being in a borderland.
Yeah.
And so if I may just make a couple comments about that.
Please,
The patients are wonderful people. They come with their families. They come with the whole support system. But we see a disease process here that oftentimes is more advanced or varied. So like something that most people would not be exposed to if they live. I'm just use a comparison city where, and some of those are social barriers or access to care barriers. And so, for example, if you notice something in your mouth and you went to see your doctor or your dentist and they were like, hey, that's a really small thing. It usually gets removed and then there's no progression of the disease. Whereas here we see, like, for example, I mentioned some of my patients come from northern Mexico and they've never seen
a
doctor before.
Right.
And so what they have so the cases are really unique and very advanced in many regards. So that kind of speaks to tying in some of the appeal. And that's why when Dr. Schubert said, man, we've really needed something like this here, I totally agree. And we get to make our mark on people. Like, so these fellows that leave are going to go to other hospitals, other communities, and El Paso will have left a mark on them. And so, it's in some ways, it's really, there's a beauty to that, right?
There absolutely is. There absolutely is. And sometimes this program, and I love that you said leaving a mark, because one of my questions when Dr. Schubert was talking, and the way that you stated your point was sometimes, how do you know, and I ask about this question on most shows, how do you know when it's time to go see a doctor about something? And I say this, head and neck, you were talking about head and neck, jaw cancer. When is something not right enough for you to go, I should go see a doctor about this? And let's talk about the people who aren't usually going to see their doctor. They're not going to their dentist every year. They should, but sometimes for whatever reason, they're not able to. And that's another hard one to answer. But what are they looking at? Symptoms? The symptoms seems like a small situation here, a small word to use, but what are you looking for?
So any pain, discomfort inside the mouth that is persistent for more than 2 weeks should be examined. Any mass, ulcer, or bleeding spot or white spot, things that doesn't look right inside your mouth, they should be evaluated. Also, any patients who has any lumps and bumps of the neck, that's an indication for possible disease. So they should get an evaluation. But in the community, most of our referrals come from the general dentist because patients just go for a cavity and they find that they have a mass in the tongue or in the palate and they refer the patient. So that's why I want to encourage any patient that or person in the community that is suspicious for anything that is not right in their head and neck area to come and see us so we can do an exam and talk about it.
So the neck, I feel like that might be harder. So the mouth, I feel like, we're eating all the time. You can feel pain and what have you. And sometimes I have thyroid issues. So my thyroid is constantly checked. But sometimes I feel like the neck is so hard to think, well, yeah, that's growing a little. It's growing a little bit more. I'm just, my neck's sore, and that's why that question comes about. When you're talking about neck cancer, what type of cancer is that usually? Are we talking about thyroid cancers? Are we talking about, the larynx? What all is in the neck that could be cancerous? I know that's a silly question, but there's a lot going on in there. Where do those cancers start? And I'm asking that to either one of you. Who wants to take that one?
Sure. Yeah. So for females, for women, the thyroid actually is a very common place.
Okay.
And most people are connected to their primary doctor. And so at times they'll check, they'll do an exam of the neck. And if there's anything that's abnormal feeling, or one of the common complaints is, man, I can't, I feel like I'm swallowing, but it feels like it just doesn't move the same way or it gets stuck. So those should be indications that there might be some compression or something in the neck that's not, and it's highly variable depending on the person, right?
Of course, yeah.
Ear pain that doesn't go away.
Ear pain, I didn't think about that, right.
So not necessarily like middle ear problems where, swimmer's ear, but sometimes there can be something in the back of the throat that can cause a persistent pain back there, and it'll present as some ongoing ear pain. So if things persist past a few weeks or that should be an indication to someone that there might be something in the back of the throat. And then as Dr. Schubert mentioned, if there's a bump in the neck, It's normal for that to happen when you get sick.
Right.
The lymph nodes get enlarged.
Yeah. To make a sore throat.
But so if it doesn't correlate to an infection, and it persists after 2 to 3 weeks, you should have it evaluated. But you're right; it is a harder question.
Yeah, and it's easier for me to ask it, but it's so difficult for someone who's listening, going, "Well, I've had this aching, this and that and the other."
Just if you're in doubt, just have an.
You're in doubt. Go, and that's a great question too. In this community, sometimes if you do not have a doctor, and the reason I say this, UMC has a lot of standing urgent cares. I always get mixed up between the words urgent care, emergency, that they can go and just check this out if you don't have a primary doctor. I feel like there's a lot of people in town that don't have a primary doctor. We only have about 2 minutes left, and I didn't really get to ask you if there's something that you didn't talk about that you'd like to. Is there anything that we forgot to talk about? And if not, we can sit here and talk about it. Oh, can I say something? Can I brag about him too really quick? Has nothing to do with medicine.
Perfect.
This man holds 4 passports.
Oh, yeah, that's
just
right.
saying. He is the spy that can fix your head and neck. And also, if you need to get out of the country really quick, Dr. Schubert's your guy.
I'm not KGB or nothing like CIA or nothing like that. It just happened like that.
These are conversations we have before the show starts. It's always kind of fun. Anything that we haven't touched base on yet?
Yeah, I would just would like to mention, and because all this surgery might sound very scary to the patients or the people in the community, but not all the surgeries are like this. There's some cases that is even if it's a cancer, but we catch it very small. Surgery is very minimal, and we just need to do a surveillance. So I don't want people to get discouraged of coming to a consultation because they think they will get a big resection and leg to the bone.
Right.
No, in many cases, we catch things early and we can correct them before they become like that.
Mm-hmm.
And even if it becomes like advanced, patients, I think they need to come and see us because even if this is a deadly disease, we would fight for you guys to cure you. Even if they need a surgery that is going to prolong their life even 5 minutes, it's worth it.
Agreed. Right.
So we're cancer hunters. Somebody call us like that.
We're cancer hunters.
And we want to help the community, so we're here for you whenever you need us.
You're cancer hunters and killers. I like that.
Yeah.
Thank you so much, Dr. Schubert, Dr. Brockhoff. You guys have been an absolute pleasure to have here. And again, sometimes for me, the conversation we have before and after the show is so much fun too. But a huge thank you to UMC, and also a huge thank you to the El Paso County Medical Society that brings this program to you. And please know you can watch this program again on several different platforms. You can go to pbselpaso.com, look for Watch in the El Paso Physician. You'll be able to find it there. You'll also be able to find it on the El Paso County Medical Society website, which is EPCMS, just think of the acronym, .com. And if you look on YouTube, just look up the words The El Paso Physician, and you will find different shows on there. And depending on what your ailment is or what you're interested in, usually you'll find several on there. So you guys get to watch this back, which is always cringeworthy, by the way. So anyway, thank you so much for joining us. I'm Catherine Berg, and this is the El Paso Physician.